She had suffered from type 2 diabetes for 10 years. She had been on oral anti-diabetic therapy, metformin, and others. Uh, she took combined therapy for holding level of glucose under the control. She had been unable to control the blood glucose level adequately. Uh, she took a lot of medicine, but her blood sugar level isn't under the control. Additionally, she has 1 year history of amenorrhea, generalized fatigue, and weight loss for the last 1 year. On examination, her vital signs were within normal. Physical examination revealed acromegalic corsned facial features, but she had no clear-cut cushingoid features, symptoms, and acral enlargement. Anthropometry and laboratory tests were follow height 150 centimeters, body weight 55 kilograms, body mass index 24.44 was determined. Uh, we performed some examination, laboratory examination, and we determined hyperglycemia. Basal hyperglycemia was 202, and postprandial glycemia was 280 milligrams per deciliter. Glycated hemoglobin level was 11.8. Um, what your opinion about possible reason of changes in our patient? Can you say what problem do you suggest in patient organism?
She has acromegaly, I have heard somewhere. Acromegalic corsal facial features. She
Uh,
has,
I don't think she ha- oh, she has? Oh, okay.
yeah, and she has also overweight. I mean, the body mass index is higher, increasing overweight.
a little bit, not a lot of. Yes, because she weighed 55 kilograms, but her height is 150. And her body mass index isn't very high. It's
Okay.
in the body between overweight and normal weight. But she has some typical acromegalic changes from the appearance, not all. Yes, Samreen.
Doctor, can you hear me?
Yes, I
Yeah,
hear.
I think it's like she has some kind of like acromegalic feature. Um, but then again,
What are the typical signs of
well,
acromegaly?
um, I think Doctor, what do you call that? I
This is
think that
unproportional grossing of the extremities, like hand, foot, or head.
yeah,
Yeah, or head.
Parts, some parts of the body
yeah,
is
Yeah.
enlarged, yes, is
yes,
increased in the size, and it could be extremities. It could be some parts of the patient face, nose, lips, chin, and we can note these typical changes in the patient appearance. It does not mean that patient could have everything,
um,
all symptoms.
also like the patient does kind of like has a pituitary adenoma,
Mm.
and also a little elevated IGF-1 level. alongside like some of the hormones are like kind of a little abnormal. uh, but then again it can be doctor like a secondary to the pituitary adenoma. um, Maybe because also she has like a long-term diabetes, which is kind of like um how do I say, which is making her hormonal imbalance. um but I think this acromegaly is kind of like secondary to the pituitary adenoma, not like just she has acromegaly.
We should examine this patient, and we cannot say, according only subjective and objective information, what is the base, what is the course of these changes. But first of all, when we suggest uh, acromegaly in our patient, what test should we recommend and what test should we provide it for determining the changes, specific typical changes in the patient's organism in case of acromegaly.
I mean, doctor, we can for acromegaly we can check kind of like we already like did the IGF-1, but then we can like confirm with that again. um and also like for the how do I say, like is it, but doctor, for the acromegaly is the this IGF-1 level is already elevated in this case. So uh
And our patient has increased level of AGF1 level,
yeah,
uh, 735 milligrams per liter.
yeah, doctor.
Um,
The reference is like 101 to 267. And
yes,
yeah,
and can we measure growth hormone for determining diagnosis
the,
or not?
so
Yes, we can.
we can check for the growth hormone, which is like
Is it reasonable to measure growth hormone, or should we use some other test with growth hormone,
I think
except direct level of it in the blood?
um maybe doctor, I think growth hormone measurement would be appropriate with the IGF-1. But then again, the growth hormone can be like excess too, because if there's like this kind of like benign tumor on the pituitary gland, um, so maybe something else we can do to determine if the acromegaly is there.
Mhm. Uh, who can add own opinion, Christabel?
Um, my opinion, I don't think we should measure the growth hormone because I think the IGF levels, it goes in hand with the growth hormone. So if that's increased, then maybe the growth hormone is also increased, since they're both are for the acromegaly.
Yes, growth hormones also is increased in the case of acromegaly, but why do we don't measure direct quantity of growth hormone?
I mean, doctor, for the growth, not the direct one, like we can test the separation test for the like
Yes, we can provide oral glucose tolerant test and find
OGTT.
changes, typical changes in growth hormone concentration
Yeah,
in the blood. But why don't we do the direct testing of growth hormone concentration? Do you remember?
Doctor, you mean why we measure IGF-1, not growth factor?
Yes, yes.
But IGF-1 is the insulin growth factor one, and related to the insulin and the high level, it's also lead to acromegaly or
uh,
gigandis. Why we
Uh,
need to measure again growth factor?
maybe doctor, because growth hormone like secretes in like spikes, like in one like fluke, and there can be like very high level, and it won't like really um but how do I say, like it will be very high during the night time, and random GH can be like it can be like differentiate a lot, so that's why we go for the IGF-1 or the OGTT rather than just direct growth hormone regimen.
Doctor, I have
And
other idea. I have other
What
idea.
what it is.
Is the adult, its growth factor not now works? I mean, for children in puberty, it can increase the growth factor.
Influence of growth factor in different periods of the age is different, of course. In periods of quick growth the influence of the hormone and quantity of the hormone is higher. And of course, we should compare growth hormone level due to patient age and patient sex. But growth hormone could be changed, concentration of growth hormone could be changed in the patient organism during a day uh, very quickly. And we cannot understand, and we cannot make analysis what factors can change and can have influence in this moment on the level of growth hormone.
Yes,
So
doctor. Like it's more unstable. IGF-1 is like a more or like more stable, and like well, the it
stable and constant
yeah,
level of insulin like growth factor
yeah.
one, it's more stable concentration, and we according this concentration we could make conclusion about activity of growth hormone 2 and growth factors in patient's body too. For making diagnosis, it's more uh, adequate parameter, more stable parameter, the level of growth, direct level of growth hormone. But we know that glucose intake have negative influence on the hormone, growth hormone level, and we can provide growth hormone oral glucose tolerant test. We with interval 15 minutes propose patient drink liquids, drink sugar solution with 75 gram of glucose in it. And after that, we will measure uh, three or four times level of growth hormone in the patient's blood every 30 minutes. 30 minutes, 16, 90, and 120 minutes after drinking this solution, and decrease the level of growth hormone uh, after this test will be adequate for, will be normal variant for healthy people. Complete decreasing. When the patient demonstrate increased level of growth hormone, uh, for us, it's symptom of increased production of growth hormone in the patient's body. Uh,
but is it okay to perform suppression tests against people who have a high sugar level? I mean,
of course, it's difficulties for patient who has increased level of the blood sugar. We should control because we could bring patient in hyperglycemia. You are right. We first of all should control the sugar level. Patient should get not maybe not oral medicine for decreasing and for controlling sugar level. We can use insulin for normalization of carbohydrate metabolism before doing this test. But when we don't have other abilities to confirm diagnosis, we can provide the test, but we should control very carefully sugar level, of course, and our patient has poor control of carbohydrate metabolism, and we should prepare this patient for this investigation. Of course, she has insulin-like growth factor 1 levels increased, extremely increased, but scientists and doctors was provided Hormone Rost oral glucose tolerance test 2 for this patient, so it was possible and finally they made diagnosis of acromegaly. In the same time, different other hormones was examined: prolactin, TSH, thyroid gland hormones, follicle stimulated hormones, which was increased, luteinizing hormones, adrenocorticotropic hormones was examined too, level of cortisol, and after performing magnetic resonance imaging, doctors determined pituitary adenoma. Of course, in each case, when the patient has suggestion about pituitary adenoma, we should control all hormones of the anterior lobe, posterior lobe, when we have some suggestion about changes in this level of hormones and when we have definite clinic. The patient was diagnosed with acromegaly and acromegaly-associated exacerbation of diabetes mellitus. Very often in the clinic, we will find combination of acromegaly with diabetes mellitus. We should remember about it. And in this case, patient has additionally increased production of follicle stimulated hormone and luteinizing hormone too. So she has different changes in endocrinological balance, hormone balance in her body. So very often this adenoma can produce not only growth factor in increased amount. Some other hormones can be changed too, and other hormones can be increased too, and we should determine it every time when we deal with such group of the patient. And what is the variant of the treatment can you propose for our patient?
Doctor, we can we can go for like surgical evaluation, maybe.
First of all, we can
If
propose when it's possible, when it's adenoma grows and give for us disability, when adenoma is complete isolated, when it does not grows into their other parts of the surrounding tissues, we can provide surgical treatment. When we don't have ability to provide this variant of the treatment, what
Maybe we can do the human growth hormone receptor antagonist, or maybe dopamine agonist too.
yes, as a variant of medication. And what else can we provide?
Maybe
Radiation therapy.
radiation therapy.
Radiation therapy. So we have 3 variants of the therapy. First variant and the best variant, it's surgery when it's possible. Second variant, it's radiotherapy. And third variant, when the previous are not effective, or when the previous methods of therapy aren't possible, we can provide medicine, only medicine treatment. Also, we can provide medicine treatment before surgery. We can do antagonist of growth hormone for patients for depression, activity of this adenoma. But of course, when it's possible, we recommend, first of all, surgery treatment for such a group of the patient. It will be the best variant. And of course, we should control her level of sugar. We should control all other organs which are in the risk of affection due to increased level of the glucose in the blood. It's kidney, it's heart, uh, complete cardiovascular system, complete blood pressure level, atherosclerosis, lipid metabolism too, because increased level of the sugar is a high risk factor for a lot of variants of pathology in the patient's body. First of all, vessels are affected, and through the vessels affection and the telin affection, brain, heart, kidneys, intestinum can be involved in the pathological process and could develop uh, changes. So we try to keep control over their carbohydrate metabolism, but we control functions of other organs, kidneys, heart. Don't forget about liver, because liver is affected too due to too high increased accumulation of the fat in the liver tissue, and as a result, liver dysfunction too can be observed in patients with diabetes mellitus. So it was the first clinical case, and you have seen the combination of diabetes mellitus, which started before changes in growth hormone production, but we remember that early stages of increased production growth hormone can be unnoted. We don't know definitely when did process start. Maybe 10 years ago. We don't know. We cannot guess about speed of the process progression too. So maybe diabetes mellitus with duration of around 10 years and problem with growth hormone factor producing have the same duration. We cannot guess about it. When we start to see symptoms of acromegaly, we understand that it isn't first time, it isn't early stage, it's stage of clinical manifestation. It's middle stage of acromegaly. First initial stage is unnoted due to lack of the symptoms. Middle stage with clinical manifestation, with apparent changes in the patient appearance, and you remember that acromegaly lead to enlargement of internal organs too, but due to these changes later, some dysfunction and dystrophic processes could be developed, and patient in late stage of acromegaly could have a lot of dysfunction, a lot of variants of internal organs insufficiency. And first of all, cardiac insufficiency. It could be kidney insufficiency too, kidney problem, kidney insufficiency. increased blood pressure level, and other signs of internal organ disorders as a result of their enlargement and changes due to increased level of growth hormone production. So not only changing in patient appearance will be typical for acromegaly. These symptoms help us suggest this diagnosis, and it isn't it's easy to guess a diagnosis of acromegaly when we note typical patient face. For example, big hands, big foot, uh, big parts of the face, acromegalic face is noted. But we know that internal organ are affected too, and could have definite changes from their function. And it's very dangerous for patient because this pathology will always in progress. So we should try to remove inadequate quantity of growth hormone in the patient organism for saving patient's life and for saving patient's health too. It was first clinical case. Second, we have 44 years old man, Japanese man, referred to the Department of Internal Medicine. He had severe hyperglycemia, which detected during a general workplace checkup. The patient experienced mild hyperglycemia during a medical checkup 5 years before admission, but patient did not take any medicine, and those changes wasn't into the patient's control or doctor's control. So carbohydrate disturbances is progressed, and today, after 5 years, patient has severe changes in the glucose level, blood level. Also, we can see specific changes in the patient's body. How can you describe changes in the foot, arms, and other? Who can describe these pictures?
I think phalanges are, I'm sorry.
Yes, Miniki.
Yeah, I think phalanges, extremities are enlarged, and also the tongue is a little bit swollen, kind of like a acromegaly type of looking, I
So
think.
we see enlarged toes and enlarged fingers, patient arms and foot, enlarged tongue due to maybe swelling or due to hypertrophy. We perform X-ray examination of the hands and of the feet, and we determine increased quantity of soft tissues, hypertrophy of soft tissues, and CT scan of the brain was determined a pituitary tumor involving the left cavernous sinus. You see the very big size of this tumor and growth in surrounding tissues and cavities. So, can we treat what diagnosis is suggested?
I would say acromegaly because I can see the elongation of the face too. I don't know if it's just the bones, but then protruded, like eyebrows part. And
It's
yeah, so
not easy to say about changes in their face because I think
Sometimes, yeah.
patient has horizontal position, so his face a little bit changed due
Okay.
to position, but
Okay.
tongue is enlarged, definitely.
Hmm.
Maybe specific change, nose a little bit enlarged, eyebrows can be too enlarged. It will be typical for acromegaly. It's
Yeah.
difficult to say does the patient have these changes or not due to not so clear photo for us, but it's
Like
possible.
on the X-ray, I can kind of see little protrusion here, like there on D, like X-ray D, you can kind of see protrusion above
Mhm.
the eyes, the bone structure. I see, and yeah,
What should we check in this case additionally when the patient has so gross size of so big size of tumor or pituitary tumor and growth into the surrounding tissues? What should we
maybe
check?
intracranial pressure. You
Uh,
can
Metastasis?
check.
what else? Manel, maybe do you?
And
Metastasis?
then other,
Metastasis, yes, of course, but we make cranial.
maybe maybe like neurological symptoms, like if he has any like a numbness, tingling sensation,
Uh,
or like
Do you remember yesterday we discussed that typical change, neurological and not only neurological changes will be typical for big size of the tumors of this region and almost patient with different variants of hormone disturbances. All group of the patient could have some typical changes. What nerves are close to this location?
Doctor, like
like
also like
optic, maybe
Optic,
optic
yes,
nerves, no,
yeah,
optic
optic
chiasm. Yeah.
nerves.
yeah.
So we obligatory should check visual disturbances. We should ask first of all, and patient could have defects of visual fields, uh, but sometimes patient don't tell about it or these changes cannot be so significant and we should provide ophthalmic examination but in our patient it was made and no vision loss due to pituitary tumor was determined. So our patient does not have any problem from their visual function, but it's possible due to big size of this tumor and
Also,
type
doctor,
of growth. In, yes,
doctor also like shouldn't we check like if it's a functioning tumor or a non-functioning tumor? Like, for example, should you not check like the other levels of the hormones like prolactin,
yes, we should check all hormones obligatory.
corticotropin?
We don't know, we absolutely don't know this tumor produce increased quantity only growth hormone or some other hormones.
I mean, for example, this the X-ray that we're saying, the gignetism, it can be happening because of the growth hormone. If it's a growth hormone producing tumor, that can kind of give this kind of tough stump, the growth of the extra tissues.
Yes. And what do we have more from the objective examination? Patient height is 168 centimeters, body weight 77 kilograms, body mass index 27.3 kilograms, blood pressure 110 and 64 millimeters Gauge, heart rate 17 per minute, body temperature is normal, hemoglobin, glycated hemoglobin is 15 point
That's very high, doctor.
too high.
Yeah.
And random blood glucose level, it's mean we don't know, is it postprandial or is it fasting glucose level? 33 milligrams per deciliter. So level of glucose is very, very high, and level of glycated hemoglobin is too high. It's mean that last minimal 3 months, patient has very serious disturbances in carbohydrate metabolism. One moment. It's physical exam. A routine physical food examination for diabetic patients. First, patient wasn't suggested about acromegaly, but due to extreme grave disturbances of carbohydrate metabolism, patient was examined for the diabetic foot, and during this examination was determining enlargement of the both feet. So for doctors wasn't so clear possible diagnosis of acromegaly. First, when the doctors, when the medical staff visited this patient in own clinic. But after checking problem due to possible diabetic foot, enlargement of both feet was determined. The feet had no pitting edema and were not painful. Skin color and temperature of the skin were normal. Additional physical examination disclosed hyperhidrosis, jaw malocclusion, prominent supraciliary arcs, and enlarged hands and tongue. We in like in the first pictures, first photos. And due to these changes, the patient was transferred to the endocrinological clinic for examination and determining the diagnosis. And
We
during
should dose the cortisol. Maybe we should dose some the hormones, because we don't really explain why.
yes, we should control all endocrinological parameters of pituitary, hypothalamic pituitary system, because when we suggest acromegaly, we understand that production of growth hormones can be increased, and very often the reason of these disturbances is tumor process, cancer process in the brain, in the
Yeah.
hypothalamic pituitary region. But we don't show you that this tumor produce only growth hormone or in inadequate quantity, or maybe other hormones production are destroyed too. So we should check everything. So we find growth hormone is increased, extremely increased, but we don't know, we cannot make diagnosis only on the growth hormone level, because we know about big changes in the level due to influence of external, internal factors, part of the day too, time of the day, time of measurement, stresses, and other factors. But in the same time, insulin-like growth in factor 1 is increased in 2 times. Random blood glucose level, dry 330 is increased. Glycated hemoglobin, we discussed it, too high. TSH in normal range. Thyroid hormones in the normal range. Luteinizing hormone a little bit decreased. Follicle stimulated hormone in normal range. ACTH hormone is in normal range. Cortisol isn't changed. And arginine vasopressin, it's antidiuretic hormone, in normal range. So all of hormones except luteinizing hormone are in normal range.
We are more suspecting the tumors surinarian, because here all the ACTH, all the hormones are not in the normal range. We have
Yes,
we have
we have only extremely changes, not extremely changes only in growth hormones and insulin-like growth factor. Significant changes. And of course, glycated hemoglobin and sugar level too is increased. But when we talk about brain hormones, pituitary system hormones, we have only increased level of growth hormone. So we can suggest in our patient acromegaly due to increased level of insulin hormone, insulin growth factor, and growth hormone. And what test can we provide more for this patient for determining diagnosis? And
we can try to maybe use the test of the dexamethasone. If we administrate the dexamethasone, we will see if there is we will stop or not the
using the dexamethasone suppressive test, is it reasonable for this patient? On what hormones dexamethasone has influence? On what type of the hormones can dexamethasone suppress?
it will produce a retrocontrol on the secretion of the cortisol and
But cortisol and ACT hormone is in
ACTH.
normal range.
Okay,
So,
no, it's not a good idea.
Additionally, don't forget that our patient has too high level of glucose and very, very high level of glycated hemoglobin. So when we use dexamethasone, of course, the dose isn't very high. We could stimulate increased level of glucose too. And in the same time, it isn't reasonable to do this test for our patient because ACTH and cortisol are in the normal range.
Yeah, right.
I mean other tests. I mean growth in hormone test with oral glucose tolerant test. We can provide for this patient too. And in case of pituitary adenoma, which produce increased level of hormone, growth hormone, we can see absence of depression in this hormone production after using after using loading of with glucose. But I think it isn't reasonable too because patient has very high level of glucose and we have information about decompensated carbohydrate metabolism, completely decompensated carbohydrate metabolism due to level of glycated hemoglobin. So we will not bring patient in so high risk of hyperglycemia. We can provide corticotropin releasing hormone test, which could demonstrate changes from the ACTH and cortisol, but it isn't very reasonable for this patient. In EKG examination, we find first degree atrioventricular blockade. PR interval was increased but was constant, and patient did not have any aesthetic changes. And the echocardiography demonstrated a left ventricle ejection fraction 55%, diffuse mild left ventricle hypertrophy, and mild thickening of the mitral valve. So some changes in the heart region are present. I don't remember what was the blood pressure level in our patient. Do you remember? Patient
I
has,
think it was not. Oh, sorry.
it wasn't increased, but in the same time, patient has hypertrophy of the left ventricle. So this hypertrophy could be result of acromegaly too, result of increased level of growth hormone, because of course, when the patient has increased blood pressure level, it makes some definite influence and make heart accumulate the myocardial mass and turn to the hypertrophy. But our patient has no information about previous increased blood pressure level, arterial hypertension. During objective examination, without any medication, patient has normal level of blood pressure and a little bit decreased blood pressure level. So in the same time, he has left ventricle hypertrophy, and the changes in the conductive system of the heart. So it could be a result of negative influence and enlargement of the heart as a result of increased level of growth hormone. Carotid ultrasonography revealed no atherosclerotic changes, so patient does not have atherosclerosis signs, patient does not have arterial hypertension, but in the same time, he has changes from the heart as changes in conductive system, left ventricle, I'm sorry, first degree atrioventricular block he has, and he has ventricular hypertrophy. The tumor was we cannot recommend for patient treatment with surgery methodics due to invasion of the tumor in cavernous sinus. For this patient was recommended somatostatin receptor ligand treatment, and patient took medication.
Sorry, doctor, based on this on the size of the tumor, I think that it was more appropriate to recommend the somatostatin receptor agonist conjugated to radionuclide, like the Lutathera, because if the tumor is expressing the somatostatin and due to this size,
Mhm.
trying to control the tumors using the combination of this radiolabeled somatostatin agonists will be more efficient than only these, old molecule of agonist of somatostatin.
Uh, Maybe it's possible, but in this clinical case was used somatostatin receptor ligands, and as a result, patient has. I try to make picture more. You see examination patient during some period. I cannot say definitely in what period. Just I try to find. Mm. During follow-up and 5 months after starting therapy with lanreotide, laboratory data revealed decreased circulating levels of growth hormone with increased dose of lanreotide. And during magnetic resonance imaging study, we will find decreasing of the tumor size too. Low level of growth hormone will decreased, and decreased level of insulin growth factor too. And you see the changes in the size of tumor in our patient after 5 months treatment. Not 5 months. The last pictures, it's after 24 months after treatment. So patient took medicine during 2 years, and as a result, the size of tumor will be decreased. And during follow-up, no therapeutic response to lanreotide was observed after time of using this medicine, and patient later was treated with pasireotide and bromocriptine. Combined treatment was recommended for this patient. And when the tumor size will be definitely decreased, and it could lead to the appearing indications for surgery treatment of this tumor and surgery removing of this tumor for this patient. So such patient should be under the doctor's control, and when it's possible, surgery treatment can be recommended as a next step in the treatment of this person. So, in the second clinical case, you see combination of diabetes mellitus with acromegalia too. And very often in clinical picture, we will note and we will have such combinations. You shouldn't forget about it. It's very typical for acromegaly combination with diabetes mellitus. And a few words about his diabetes mellitus and carbohydrate dysmetabolism. More often, it's diabetes type 2, and this diabetes needs oral medication for decreasing level of the hemoglobin of the glucose in the blood. But sometimes we have to use insulin when the patient has some complication, when the patient has acute complication as a coma, for example, or when the patient has chronic conclusion, as organ insufficiency, diabetic foot or other organs, ulcers on the lower extremities. And when the patient has so extremely high glycated level of hemoglobin, which means decompensated stage of carbohydrate metabolism, we have to start from insulin therapy too, not from oral medicines. Later, when the carbohydrate metabolism will be compensated, we can change our treatment and limit using of insulin and using oral medications. But in the as a first step, we have to use insulin for this patient for normalization of carbohydrate metabolism. Do you have question about acromegaly or not?
Maybe it's what I have said previously. So when he doesn't respond very well to the this called agonist of somatostatin. I think that really the radio the targeted radiotherapy it's used the same thing. It's used the agonist of somatostatin, but it conjugated with lutetium or with other radio elements could definitively treat the tumor and put the patient in complete remission for many years. So I think that it would be a good option to be tested in this patient case.
Yes, of course. We start from the one variant of the treatment, and we aren't sure that this treatment will be effective, or this treatment will be always effective whole period of the treatment, medicamentouse treatment of our patient. So we control over the patient condition. I try to find
Doctor, I have a question.
variant of the treatment. Yes.
Yeah, doctor. So for the treatment, lanreotide and pasireotide, like this is like this I believe targets different receptors. So do we like combine these two drug to make a synergistic effect, or we use separate drugs?
We can combine medicine, and in the second period of treatment, our patient doctors used a combination of two medication, because in this combination we can decrease doses of medicine, and we could wait for the increased effect using this combination in low doses, but with more effects from two drugs. And in this way, we could have in the clinic less side effects from each drug, because all of this medicine could have side effects, and we should remember about it. So we can use combined therapy. And of course, we control over the efficacy of this therapy, and we can change the doses, we can change some type of the drugs too when we have don't enough effect. And don't forget that we can use radiotherapy too for decreasing of the tumor size, and for decreasing the tumor activity in producing of these hormones. So we can make some combination with radiotherapy and medication treatment. First of all, we can use radiotherapy, and later add the medications. And after getting good result, when the tumor size will be decreased, we can discuss possibility of surgery treatment too. So medications and radiotherapy could be as like a stage and preparing patient for main treatment methodics for surgery. But of course, we don't sure we aren't sure that we later we can provide this methodics, because reaction of organism can be absolutely different. We could have a effect, or we could have no effect or not enough effect in each clinical case. It's very individually.
Doctor, here I have a question regarding the biopsy. Is it possible regarding the localization of the tumor and the size of the tumor? Is it easy? Is it recommended to perform biopsy, or are there any risk?
Uh, Students, what do you think about possibility of biopsy for patient with pituitary tumor?
I don't think it's a good idea because it's you know, invasive method, and that could damage other parts of the brain. So maybe it's too much of a risk if you're not doing a surgery. I mean, if you're doing a surgery operation and you know it's the only way, then you can probably do it. But
Uh,
I'm not sure if it's a good idea.
and I have a question to you, Manel, or maybe to other students too. What do you expected after biopsy?
What I expect is actually we have many targeted therapies. You know, we have, for example, a agnostic ADC, the Enhertu, which actually expressed used in many indications, including neuroendocrine tumors. We have many other ADCs under development in latest stage of clinical trials. Also, we have many vectorized radiotherapeutics with some ligand specific to some biomarkers. So if we have the biopsy, we can it will be more easier to detect the level of example, for example, the somatostatin receptor or HER2 receptor or TROP2 receptor or other biomarkers of tumors, and we can more orient the therapeutics option.
On the one hand, yes, but it's theoretically information.
Uh,
And in the same time, risks of biopsy is very high according to the type of the tumor growth in and intervention in the surrounding tissue and cavities. So patient has a very high risk of complication after this methodics, and I think it's more adequate and more reasonable to try using some methodics and controlling over the patient changes, patient condition due to using radiotherapy or using different type of the medication, like in this clinical case. And after that, make conclusion about effectivity of this treatment. Yes, Samrin, do you want to add something?
yes, doctor. So for the biopsy, because there is a thing which we follow for any kind of malignancy or tumor, which is risk versus the benefits. So if it's in a sensitive place such as this one, we will be checking if the benefit of the biopsy is lesser than the benefit of it. And also the thing that we can get from the biopsy, we can also do some sort of, like, for example, we can do a treatment with somatostatin receptor ligand, and we can see the clinical and hormonal evidence without a biopsy. Hence, in this case, biopsy isn't a very preferred way to check those things. And also, like, we can do very for this kind of cancer, we um, not cancer, like tumor, or this kind of, even if it's malignant, we do rely on more on the imaging techniques and treatment and see the result rather than just checking for directly going for the biopsy, I think.
Um, yes, it's everything is possible and everything would have sense. But in this case, we don't deal with biopsy, and biopsy wasn't in discuss for this patient. I can say about the reason, but in the same time, always risk of biopsy is very high, um, and in this case, we'll choose the medication treatment, not radiotherapy. First of all, medication treatment for decreased activity of this tumor in hormone production. And we will get, after a long period of this therapy, positive effect. And next steps of patient treatment are still in the discussing area. And I cannot say more about this situation. I don't have information, statistic information. I will try to find something about effectivity of biopsy in these cases. We oft the biopsy is used for patients with pituitary tumor. I can say you this information. Uh, we useful, we reasonable performing this interventive type of the examination uh, for patient with localization of the tumor in pituitary region or hypothalamic pituitary region. Maybe we can discuss it in the second part of our class. Now we make a short break, 10 minutes. I think it will be enough. And after 10 minutes, we discuss this tema 2, and I try to find some information about biopsy in case of pituitary tumor.
I think, doctor, according to the endocrine society, like the European Society of Endocrinology, it's like in the guideline. So if you can take a look at that, it's there, I guess.